Great, thank you, Tyler. Hi, everyone. Thank you for joining us this afternoon. My name is Brittany Lee, and I'm a policy associate with the New Jersey Healthcare Quality Institute. For those of you who are not familiar with the Quality Institute, we are a multi-stakeholder membership organization that convenes healthcare leaders in New Jersey around the common goal of improving the safety, quality, and affordability of healthcare for everybody. A few housekeeping items before we start. Please know that this webinar is being recorded and a copy will be posted to our website later today, and a follow-up email will be sent with a link to the recording as well as the provider access commitment toolkit that we'll be discussing in today's webinar. All phone lines will be muted for the duration of the program to limit background noise, but you may ask questions at the end of the presentation by typing into the chat box. Please be advised that it is not the intent of this program or its speakers to provide clinical or legal advice. The topic for today's presentation is increasing access to reproductive health services in New Jersey. Next slide, please. So as I mentioned, my name is Brittany Lee, and I am the project lead for our NJ-RHAP program, and I'm honored to have our Quality Institute board member and NJ-RHAP reproductive justice consultant, Linda Sloan-Locke, join me today. Linda has a career-long commitment to women's health, health disparities, and the intersection of health and mental health, as well as the impact of violence on health. She obtained her BSN and MPH from the University of Michigan, her midwifery certificate from SUNY Downstate, and MSW from Rutgers. She has over 40 years of experience as a midwife in a variety of settings, including Planned Parenthood, FQHCs, private practice, and both community and teaching hospitals, including serving as the Chief of Midwifery at St. Joseph Medical Center. Without further ado, we'll dive into our presentation. Next slide, please. So today we're going to be talking about some of the access barriers to contraception in New Jersey, doing a deep dive on reproductive justice and contraceptive counseling, reviewing patient and provider barriers to contraceptives, as well as strategies and best practices to improve access. Next slide, please. And similar to our agenda, our objectives for this meeting are to describe the importance of access to reproductive care, barriers to services, and strategies to increase access. Next slide, please. Great. So the New Jersey Reproductive Health Access Project is a statewide initiative launched by the Quality Institute to, apologizing for my dog barking in the background, there's landscapers outside, but NJ-RHAP is an initiative by the Quality Institute to expand the full range of contraceptive options available. And we want to do this by addressing provider education concerns as well as state policies that can improve to increase access to services. And this project would be possible without the support of our funder, Arnold Ventures, as well as our NJ-RHAP steering committee. Many of those organizations are on today's webinar, so we wanted to acknowledge and thank them for their participation in this program. Next slide, please. So the main deliverable of our NJ-RHAP program has been our Provider Access Commitment Toolkit, which we refer to as the NJ-RHAP PACT or the Toolkit. And this document is an educational document to help increase the understanding of the complex policy and payment systems involved in reproductive health services in New Jersey. And doing so around, while centering the concept of shared decision-making and reproductive justice. And that toolkit was launched on June 1st, and the link is available on this slide and will also be available in our follow-up email. Next slide, please. In addition to the toolkit, we also came out with 10 different resource documents that can supplement the content in the toolkit, and they can serve as worksheets, checklists, and things like that, so that you can really work on taking the best practices from the toolkit and applying it into your day-to-day interactions with patients and other individuals in the healthcare system. Next slide, please. Great, so now I'm going to toss it over to Linda, who's going to dive a bit more into the importance of access of contraceptive care in New Jersey.
Next slide, please. Thank you, Brittany, and thank you for having me this afternoon. So APHA says that birth control as a core component of family planning is one of the most important health success stories of our generation. Yet we're still not maximizing our success in this space, which is one of the whys for this toolkit. Next slide, please. The CDC also has named family planning as a great public health achievement, and it's estimated that for every dollar that we invest in family planning programs, federal and state governments save over $7 in part due to the prevention of unintended pregnancy. Contraception access also accounts for about 86% of the recent decline in teenage pregnancy across the country. And there are non-contraceptive benefits for using family planning as well, such as the fact that oral contraceptive use has consistently been found to be associated with a reduced risk of ovarian and endometrial cancers. Yet, unplanned pregnancy is still an issue. The CDC 618 project identifies unplanned pregnancy as one of the 6 most common health conditions, significantly impacting quality of life. Next slide, please. On a personal level, accessible and affordable contraceptives give individuals the ability to make educated decisions about their reproductive health and decide if and when they would like to have children. This type of empowerment is directly tied to increased financial stability, as well as improved health and education outcomes for individuals, families, and communities. Next slide. In this effort, we want to prioritize access over utilization. Initiatives around contraceptive services should be focused on increasing access to all forms of contraception and promoting patient-centered decision-making, rather than be focused on the utilization of contraceptives as a whole or on utilization of specific forms of contraception. We must keep this especially in the forefront when working with people who have been marginalized in our country, such as Black, Indigenous, and people of color, due to past injustices around forced sterilization and other oppressive policies that limited reproductive choice. Next slide, please. So we're all familiar, most of us on this call, I'm sure, are familiar with the chart, which lists a variety of contraceptive methods, and most of these charts list contraceptive methods in order of their effectiveness. What we need to remember is while it's important to explain with our clients and patients the effectiveness of each method for preventing pregnancy, the best method of contraception is the one that meets the individual's needs and is used appropriately. Next slide, please. Let's talk a little bit about LARCs. LARC stands for long-acting reversible contraception, which they provide continuous protection against pregnancy between 3 and 12 years, depending on the product. And we know that there are 2 types, either the implant that's placed under the skin of the arm or an intrauterine device. Both implants and IUDs require insertion removal by a qualified health professional. They can be removed at any time, after which baseline fertility usually resumes quite quickly. But for many patients and providers, there are increased barriers to LARC services due to the cost and process to obtain them. And there's also the need for a provider engagement to both initiate and remove the device. Next slide, please. Brittany?
Thank you, Linda. So next we wanted to cover just a couple of key data points that are another reason as to why it's important to address access barriers to contraceptive care in New Jersey, because our state still is far from where it can and should be in terms of contraceptive access, and this data really illustrates that. So although rates of unintended pregnancies nationally and in New Jersey have declined over the past few years, over 25% of pregnancies in the state are still unintended. Additionally, although over 72% of New Jersey women who were at risk of an unplanned pregnancy were using some form of contraception, you can see from the data on this slide that only 10.6% of those were using a highly effective form of contraception. Next slide, please. Great. So in addition to the data on utilization, it's also important to remember that there are a lot of different factors that can influence an individual's decision about whether or not to use contraception and which contraceptive they would choose. As many of us would assume, the effectiveness of a form of contraception is an item that is extremely important to a lot of women, and that's what this national 2016 study showed. However, the ease of use of a form of contraception, how affordable it was, and how easy it was to access were all also significantly important to patients in making their decision about what form of contraception to choose. Other characteristics such as side effects, non-contraceptive benefits, and partner preference were also taken into consideration. And it's really important to be aware of that when talking with patients about different forms of contraception, because there are a lot of factors that can contribute to that decision. Next slide, please. Great, now I'm going to toss it over to Linda, who's going to do our deep dive on reproductive justice and the importance of contraceptive counseling.
So reproductive justice is a concept that was defined in 1994 by Sister Song, and it is the human right for people to maintain personal bodily autonomy, to have children or not have children, and to parent those children in safe and sustainable communities. It combines the concepts of reproductive rights and social justice. And although today we're going to talk mainly and center around reproductive justice in relation to family planning and contraceptive services, it's a much broader concept than that, and we need to keep that in our mind as well. Because although the first part talks about having or not having children, it's not just the ability to plan a pregnancy, but it's the ability to maintain that pregnancy, have a healthy birth, and have a healthy child. And then to be able to parent that child in safe and sustainable communities, which touches on social determinants of health, being able to live in communities without violence, and not having violence be something that you're afraid of in your daily life. We know that in our country, there's been a long history of reproductive injustice, especially towards Black, Indigenous, and people of color, and other people who have been marginalized, LGBTI, teens, the disabled, and other groups. It can be a manifestation of systemic racism and other isms, sexism, ableism, in the medical field, as well as in our society as a whole. Next slide, please. As recently as the 1990s, documentation shows practices of sterilization without consent and coercion with financial or other incentives, or such as a requirement for receiving welfare payments in order to have LARCs inserted or to receive injectable contraceptives such as Depo-Provera. These efforts were often supported or funded by federal or state governments, and efforts such as this have contributed to the distrust of providers offering contraceptive services. Next slide. So that means that not only must we have an awareness of the history and principles of reproductive justice, but also at all levels of policy development, implementation, and service delivery, prioritizing reproductive justice means continuing to evaluate policies to ensure that they are grounded in evidence, supporting individual rights, and avoiding coercion through processes that promote shared decision-making and patient-centered care. It also means avoiding policies which, though well-meaning, may have negative unintended consequences, and utilizing best practices to ensure patient rights, education, and access are at the forefront in all our interactions, and recognizing and addressing systemic racism and other isms, explicit and implicit bias in all our healthcare systems. Next slide, please. So an example of well-meaning policies has been is LARC Zeal. Because LARCs are so effective, LARC Zeal has been noted in programs around the country. It's been described by the National Women's Health Network as institutional or provider enthusiasm for LARCs to the exclusion of other methods. And this runs the risk of hampering an individual's ability to decide what methods are best for their unique circumstances, and it can also heighten the possibility of coercion. When providers keep at the forefront the knowledge, the negative impact that emphasizing LARCs as a preferred form, or sometimes the only form of contraception, can have on individuals, particularly those who are the most vulnerable, they can provide services without fear of LARC Zeal. And some examples might be some states have had programs, have put forth programs that will pay for the insertion of LARCs for certain populations of people, but sometimes these programs do not also cover the cost of removal of the LARC. So there are unintended consequences that we want to avoid. Next slide, please. I keep looking on my computer for the button to advance the slide. So we've talked a little bit about shared decision-making. So what does that look like in the space of reproductive health? The process of shared decision-making requires clinicians to set aside their personal biases or preferences for care, offer a balanced information about all treatment options, and help patients to navigate that information and arrive at their own decisions. All reproductive health decision-making takes place within the power dynamics and social structures of patients' lives, including the history of reproductive coercion, forced sterilization, and bias between patients and providers. Using a shared decision-making model in reproductive health is a patient-centered step towards addressing that social context. Next slide, please. Next slide. So there are several models to help us utilize shared decision-making. One is the SHARE approach, which has 5 steps. Starts off with seeking the patient's participation, asking about where they are in their life and what their priorities are, helping your patient explore and compare the options, assessing the patient's values and preferences, helping the patient to collaboratively reach a decision, and then helping the patient to evaluate that decision. Next slide, please. So shared decision-making and patient-centered care go hand in hand for best practices in delivering reproductive health care. Patient-centered care places the individual's health needs, quality of life concerns, and desired health outcomes at the forefront of care and respects the patient's viewpoints and preferences. It promotes active listening on the part of clinicians as a tool to promote true collaboration and shared decision-making and uses language that is most appropriate for that patient. It recognizes provider privilege, which can affect the way clinicians present or package information and impact the intersection of client interactions with systems of care. It avoids the possibility of provider bias and assumptions influencing the decision about what information and which methods to discuss with patients. Next slide, please. So as individuals' lives and needs change, continued counseling is needed to ensure that the most appropriate contraception continues to be accessible for the particular stage of life that they find themselves in. And remembering always that the best contraceptive method is the one that the individual will use. So it's always important to acknowledge the changing needs and priorities of each patient throughout their life. Shared decision-making models are fundamental to the provision of all health care, but are especially important in contraceptive counseling. Next slide, please. So when we talk about influences and things in patients' lives that influence their decisions around what contraception they want to use in their reproductive life plan, one of the things that we need to take into consideration and consider is the possibility of reproductive coercion. Reproductive coercion is a type of domestic abuse. It includes such things as interfering with utilization of contraception, explicit behaviors to promote pregnancy that's unwanted by the woman. As I said, interfering with contraception, interfering with the patient's ability to go to a visit to obtain contraception, poking holes in condoms. There are a variety of things that have been done. Pregnancy coercion and threats of abandonment if a pregnancy does not occur. They can be either physical or psychological, and they don't always come from an intimate partner, because in some cultural circles, extended family, particularly older female relatives, might have some control in the decision-making around reproductive choices. As many as 1 in 4 women who present for reproductive health care have experienced this type of abuse, and particularly younger individuals can be at risk for reproductive coercion. So I want to just talk a little bit about the impact of COVID and telehealth on this in particular. So we have seen a big spike in the incidence of domestic violence and intimate partner violence during COVID-19, which is not, which we can certainly understand given the circumstances of COVID-19. If a person is in an abusive relationship and it's now necessary for that person to shelter in place with their abuser, there's increased vulnerability and increased risk for violence. There might be decreased access to support, as well as all the increased stressors that we see in the environment with COVID-19. And we've also seen social inequities intensify during this. So we really kind of have a perfect storm for an uptick in domestic violence. And I'm talking to you today from Bergen County. And in Bergen County last week, we lost 2 women to domestic violence. They were both killed by their intimate partners. So this is really an issue that we need to keep at the forefront of our minds when we're doing contraceptive counseling right now. The other, next slide, please. So again, these are some examples of reproductive coercion and some recommended screening questions. And the other thing we want to remember is our shift to telemedicine and telehealth. So some of these questions are really important, and they're very important to include in the context of the screening and assessment that we do of all our patients. We screen and we assess for depression and anxiety, and we screen and assess for domestic violence and intimate partner violence. And so we need to include reproductive coercion in that screening and assessment. When in times pre-COVID, we had clients in our office and we had some control over who was in the room, right? We could have a policy in our office and in our clinical setting that said that we're going to have some one-on-one times and individual time with each patient. And one good thing about COVID, if we can say that, is the increase in telehealth, because sometimes it does enable us to have easier access and connect with people who may be experiencing abuse, who may have experienced barriers to getting into the office. However, we also need to remember to make sure that when we're engaging with patients in telehealth, that they're in a safe space. They may not have the ability to control the space they're in. They may have an abusive partner who's listening in and is, again, using that ability to control by controlling the conversation that they're having with their clinician. So it is an important thing to remember as we go on with this expanded telehealth presence. And I'll put in the chat box later. If you want more information about this, Futures Without Violence has several webinars and tip sheets that go into this in more depth of what we need to remember. Next slide, please. Brittany.
Great, thank you, Linda. So now that we took a look at some of the data around barriers to contraceptive care and the importance of centering reproductive justice, we wanted to talk about what are some of the specific barriers that are preventing patients from accessing care, providers from delivering the full range of contraceptive options, and what are some of the policy and systemic barriers that are making all of this difficult. Next slide, please. So some patient barriers to contraceptive care. Coverage limitations include things like being uninsured or underinsured, potentially not wanting to use your insurance for fear of confidentiality as it relates to your use of contraception, or potential out-of-pocket costs depending on your insurance. Lack of knowledge about options is something that we saw in the data as being a significant barrier to contraceptive care. Folks not understanding what forms of contraceptive care are appropriate for them or what all of their options are. Fear of side effects is a big one. Specifically with IUDs, we hear that a lot of people have friends and family members who have had a really good experience or a really poor experience with a certain form of contraception, which can really, change how they're perceiving contraceptive counseling that they're getting, or they're, whether or not they will initiate a form of contraception at all. Also, there are population-based and cultural challenges. So limited acceptance of contraceptive use in different cultures, lack of culturally competent providers and education materials, or prior negative experience with the healthcare system or history of trauma. So all of those can impact an individual's willingness to come in for an appointment discuss contraceptive care, their use of contraception, or how long they utilize a form of contraception, and understanding what these barriers are essential to looking towards solution that can really address what's stopping patients from accessing high quality and comprehensive contraceptive care. Next slide, please. So provider barriers to care. What are some of the reasons that providers or healthcare systems have difficulty providing access to the full range of contraceptive options? Some of these are around clinical misconceptions among provider communities about certain forms of contraception, and we see that mostly with IUDs. There's beliefs that there could be an increased risk of PID with the use of IUDs, or that IUDs might not be appropriate for adolescents or individuals who have never given birth, and increasing the understanding about what professional organizations are recommending can really do a lot to change providers' understanding about what's appropriate in terms of contraceptive counseling with different patient populations. We've also seen significantly and heard anecdotally that providers, particularly those who don't work in a family planning clinic or an OBGYN office, that they have a lack of experience or comfort with these services, and that may lead them to refer out to specialized providers who are doing things like IUD insertions on a daily basis. And that really creates a cycle where individuals may have to go to another provider that they are less comfortable with or have a less strong relationship with to get access to services. And then in turn, those providers have less and less experience and comfort providing services. So ensuring that providers are able to stay up to date on their skills that they learned in training and know the current best practices as it relates to contraceptive care is really important to reduce barriers. And the next are reimbursement policies. So confusion about coverage for contraceptive care is a big one. So even if there is coverage and there is adequate reimbursement, providers or offices' misunderstanding about appropriate billing and coding and concerns about denied claims can really impact an office's overall approach to providing contraceptive care. And things like the reimbursement rates for LARCs, especially for individuals on the state's Medicaid program, could de-incentivize providers from offering certain healthcare services. Next slide, please. Great. So as we mentioned before, because of the nature of LARCs, which includes IUDs and implants, because of the provider engagement needed to initiate and remove the device and the supply chain to access the device, those forms of contraception, although most effective at preventing pregnancy, also have the most barriers often for individuals to access them and for providers to offer them. And because of those barriers, there are a lot of provider offices that choose not to offer LARC services. They feel like either their providers aren't comfortable providing the service, and the administrative burden to secure the LARC devices and to provide those services to patients is greater than the return would be. And in turn, patients either have to choose a different provider to access their LARCs with, or possibly choose a less effective form of contraception. Next slide, please. So for provider offices that do offer LARCs, patients typically have what we refer to as a two-visit experience. So patients come in for one appointment where they engage in contraceptive counseling with their provider, and either an IUD or an implant may be selected as their form of contraception. And then they have to return for a second visit to initiate that method. After that initial visit, the office then orders the device for a patient through their insurance, and it's delivered to the office. Now, the processes that happen from ordering the device to it being delivered to the office can be really complex. I've heard stories before where provider offices have to tell a patient, make sure for the next 2 weeks you answer any unknown number that calls your cell phone, because it could be the insurance company asking you information about this. And if there's any snags in that process, it can further delay the time between when an individual selects a form of contraception and when they can actually initiate it. And during that time period, a patient could become pregnant, or they can just face a lot of difficulties coming back for another appointment in a relatively short period of time, finding childcare, transportation, time off of work, things like that. So that two-visit experience, depending on an individual's circumstances, can really, change whether or not they're using a highly effective form of contraception or returning to get their form of contraception at all. Next slide, please. Great. So as I mentioned before, in that 2-visit experience, providers often order a device through a patient's insurance. And that process is referred to as white bagging, which is kind of the opposite of brown bagging, where you kind of go to a pharmacy, you have a brown paper bag where you picked up your prescription. White bagging is the version where, it's sent to the provider's office, usually through a specialty pharmacy. And under this model, the device is ordered for a specific patient and the pharmacy bills the insurer directly for the cost of the device. But as I mentioned before, there's time and other administrative hurdles associated with that process. A lot of provider offices kind of have always done it in that way, and that's kind of what they're most comfortable with. But there are alternatives to increase access to contraception specifically on a same-day basis. And one of those options is referred to as a buy and bill model. So this would involve a provider office's purchasing, for example, different IUDs through a manufacturer. Often when they purchase in bulk, they may be eligible to receive a discount on that. And they're purchasing those devices from their own capital and stocking them in their office to use when patients have contraceptive counseling and choose that form of contraception as the one that they want to use. Once they do the insertion, they then seek reimbursement for the device and for the services provided in the visit from the insurer, rather than waiting for the insurer to approve it and processing the reimbursement and costs ahead of time. So while this practice can allow for same-day access, it does require that upfront purchasing, which can have cash flow issues depending on a provider office, and they're fronting that money. So there is financial risks associated with that, as well as some administrative components to figure out exactly how to navigate that process. But provider offices that offer buy and bill models are able to provide same-day access to services for patients who it's appropriate for. It is important to remember that regardless of whether or not a provider office is keeping stocks of IUDs in the office or they're ordering it through a specialty pharmacy, that really the shared decision-making approach should be centered regardless of what the stocking and storing process is for a provider office. In no way should provider offices be pushing LARCs or a specific form of LARC or any specific form of contraception on a patient because it's what they have in stock and it's what they spent capital on. And that's particularly important to think about if a practice is going to uptake this type of buy and bill model. Next slide, please. Great, so next we're going to dive into a couple of ways that provider offices and the health system can really incorporate some of these ideas and best practices and implement strategies to increase access to contraceptive care. Next slide, please. Great. So the first one is around maximizing the full care team. Throughout this presentation, you hear us refer to providers a lot. And when we think about this work, we're thinking about providers in the broadest sense of the term. Anyone that an individual may engage with or may be involved in their care, from when they call to schedule an appointment all the way through their intake process, their actual procedure, the billing process and reimbursement process and things like that, because that full care team really plays an important role in ensuring access to services. So what does this look like? For individuals higher up in a health system, it can include supporting programs that can increase provider competency, looking into investments in some of those stocking and storing practices that we just described, and thinking about what the schedule looks like for a system or an office to ensure that providers can have enough time with their patients to really provide this comprehensive contraceptive care, that there's enough time for counseling, enough time to ensure that you can have one-on-one time with a patient to screen for reproductive coercion. For individuals at the practice management level, they can be really important in supporting ongoing training efforts and making sure that conversations and in-services aren't just a one-off discussion, but really become a part of the culture of the office. And they can also be really important in taking a look at the materials that an office has to educate patients about services and making sure that they're culturally competent and responsive to the population that they're serving. And front desk staff and other types of support staff are really instrumental, especially in the patient experience. When someone calls to schedule an appointment, asking non-leading and judgment-free questions. So, things like, you know, will you be using insurance for this visit versus what is your insurance? Small things like that, and paying attention to the use of pronouns and things like that can really make a difference in how comfortable a patient feels with the office and how likely they are to be upfront about their concerns and what they're going to need in their service, which down the line improves the provider experience and the patient experience. So front desk staff and individuals doing that daily intake work and scheduling appointments are really important to be utilized when trying to increase access to services. Next slide, please. Great, and as I mentioned before, providers' individual kind of comfort with providing different forms of contraceptive care and feeling like they have the skills to provide the full range of contraceptive options is really important. You know, especially for providers that may not be doing this on a day-to-day basis, making sure that they feel up to date on best practices and skills can really increase the experience that patients have and how successful they are in accessing the full range of contraceptive options. I think this is particularly important to think about as folks kind of maybe start scheduling doctor's appointments that were canceled or postponed during COVID-19. I've talked with one individual recently who said that, you know, they really feel like there's going to be an influx of individuals looking to receive contraceptive care from their primary care provider, where they previously would have had two separate visits, one where they see their primary care provider and another where they go to their OBGYN to get their contraceptive care. But if they're looking to maybe limit their interaction with the healthcare system and in-person engagement with providers, just to, you know, promote, you know, appropriate social distancing and things like that, they may seek contraceptive care from a physician that isn't specialized in that. However, there's a lot of contraceptive care and counseling that those providers can offer if they feel comfortable doing so. So seeking out training opportunities and hands-on experience is really important, specifically as it relates to things like LARC insertion and removal. A lot of the manufacturers of those devices offer hands-on training or virtual trainings as it relates to those services, and talking with practice leadership and other physicians about, you know, what types of services are provided in the office and the small steps that folks may be able to take to increase those access and become more confident in their skills. Next slide, please.
And also, another way to look at this is, again, prioritizing patient-centered care. So prioritizing patients' priorities and choices and recognizing patients as experts in their own lives leads to more productive conversations with their providers about their concerns or questions. Centering the concepts of reproductive justice ensures that these choices and decisions are respected. So what does this look like? Well, as Brittany said, scheduling models which allow for sufficient time for comprehensive contraceptive counseling. Developing and adhering to policies that ensure that providers can speak to patients without a partner or another person present. And again, remembering during telehealth to ensure that the patient is in a safe space to talk. Using shared decision-making models to ensure that contraceptive counseling is a collaborative process with the patient. Next slide, please. And we know that our patients do not live in a vacuum, right? Our patients live within relationships, within families, and communities. So engaging our communities is an important step to take as well. When providers and organizations engage beyond their typical environment and more within their community, we can develop true partnerships, create greater trust, and improve patient satisfaction, and also increase effective organizational decision-making that really reflects and mirrors the community's needs. And what does this look like? Well, things like participating in local health fairs and community events, invitation to community members to participate in an active way in advisory boards, listening to their words, and utilizing their words to help inform processes and services that are offered, and hosting support groups or education sessions that are not only open to the community, but those support groups' contents can often be determined by community input. Next slide.
Great, thank you. So before we turn it over to Q&A, a couple of next steps and action items. So you heard us mention multiple times our NJ-RHAP toolkit, and that's available at this link along with the resources. We also have hard copies available if folks prefer that method of reading, and you can feel free to contact me. My email is on this slide if you're interested in those. We also have an NJ-RHAP PACT pledge that looks at the most important considerations that we raised in this toolkit, things like reproductive justice, shared decision making, and what it means to be an individual in the system that's committed to increasing access. So we welcome you to take a look at that, print it out, sign it, hang it somewhere with your number, and share it with individuals that you think may be interested in signing that pledge as well. We briefly talked about some of the importance of billing and coding for contraceptive care and the stocking and storing practices, but we will be doing a specific webinar around that sometime in end of August or early September. So stay tuned for more information about that. And finally, in addition to this presentation, we're also doing more targeted presentations with provider groups, health systems, and professional organizations around the content that's in this NJ-RHAP toolkit to help take it from information that's up on our website and in paper to real provider behavior change and supporting systems that are looking to take steps to improve access. So if you or your organization are interested in hearing more about those opportunities, feel free to reach out to me. And now I'll turn it over to Tyla, who will moderate any questions that folks might have.
Great, thanks, Brittany. So if you have questions, please make sure to type them into either the chat box or the Q&A box. We won't be unmuting any lines. So please do that now. And while we're working on that, I actually have a few questions of my own. So first, how might the COVID crisis and concerns patients might have about going to the doctor's office impact patients choosing other forms of birth control besides LARCs, since they require so much in-person interaction?
Sure, I'm happy to start and then have Linda jump in, especially because she has that great clinical knowledge. Over the past few months, as we look at the impact that COVID-19 has had on contraceptive access, I think we're seeing a couple of different things. We definitely saw that the utilization of LARCs, so especially new insertions, dramatically decreased as individuals were not interested in coming in person for services. There also was some guidance released by various professional organizations about potentially increased effectiveness times of different forms of LARC. So that might also tailor, if an individual may be able to wait an extra, if waiting a couple of months wouldn't change how effective their form of contraception was, they may choose to delay that removal. So ensuring that providers can understand that and help patients decide what makes the most sense for them is important. In New Jersey, we are especially lucky that Governor Murphy, from the beginning of the public health emergency, has specifically called out family planning services as an essential medical service. So individuals across the state were continuing to provide care, and we're using telehealth as needed for individuals who didn't have to come in person or who preferred to have at least some form of their visit in person. As Linda mentioned before, the expanded use of telehealth has been really great, and we hope to see that continue for contraceptive care. Using telehealth for contraceptive counseling is a great in-between for that, 2-visit experience versus same-day access for LARC, for example. So if an individual is able to have a visit with their provider where they're discussing their contraceptive options via telehealth, maybe they're doing that on their lunch break, or the provider has later hours available for telehealth, they can then still do the process where they order the device to the insurance company and have it delivered to the office, but the patient might only need to come in person once because of the use of telehealth. So I think although we're seeing some reduction in in-person visits, individuals are still accessing services, and there are some ways that telehealth can really be used to maximize access to the full method, the full range of contraceptive methods during COVID. Linda, is there anything else you wanted to add on that?
Yeah, thanks, Brittany. I think you covered a lot of it. So nationwide, Guttmacher has said that about 1 in 3 women has had some problems with access to family planning, reproductive health care during COVID. I think, again, we're lucky in our state because family planning and reproductive health care has been identified as an essential service. And I think one of the other things that we've begun to understand with telehealth is that we can start people on different types of contraceptives with a telehealth visit. And there was less understanding of that prior to COVID. I think people were a little bit more hesitant to initiate oral contraceptives and other methods of contraceptions over telehealth. But as we've been pushed into this space, we've more people, I think, have begun to understand that that's an effective and patient-friendly way of providing the services.
Thank you both for that information. And we do have a few minutes left for questions. So if you have any, please do type them into the chat box or into Q&A. Already getting some nice comments about all the great information you guys have offered. One question that just came in is, for LARC, how do FQHCs overcome New Jersey Department of Health licensing barriers that require large procedure rooms with ensuite bathrooms and sterilization suites located within a few steps of those procedure rooms and having very high levels of air exchange?
Brittany, I'm going to let you take that one.
Sure. I wish I had a clear answer to how to overcome that. What I will say is that some of these, facility-related barriers are really important to address, especially because they're really limiting access to services for our most vulnerable residents in New Jersey. I think getting clarity and using an evidence-based approach to figure out where those requirements came from, and if there is any clinical reason that they are necessary, and then steps that can be taken to either support FQHCs in becoming in compliance with that, or addressing policy change that needs to be made to increase access in those settings. But it's definitely an issue that we are aware of and hoping to address as part of our policy-related initiatives.
Great,
I will also add on that note that one important thing, although not a comprehensive solution, is for provider offices that are not offering services or the full range of contraceptive services to patients, having a really strong referral network is important. So obviously we want to ensure that individuals can get access to the full range of services wherever their provider of choice is located. But when that isn't a reality for a variety of reasons, having strong relationships with the individuals that you're referring patients to and doing that warm handoff and follow-up is really essential. And it's extra legwork, but can really make a difference in terms of an individual following up with their care and maintaining those relationships.
Thank you both. And I think to Brittany's point, having these conversations and doing presentations to provider groups and facilities and hearing all of these issues that are coming up and working with policymakers in the state on this important topic is going to be important for us in the coming weeks and months to really hear about all those issues that may need to be addressed as well. If any other folks have questions, please type them into the chat box. I do have a couple more of my own while we are waiting for audience questions. One that I thought was really important, and Brittany, I know you touched on this a little bit, but how can non-clinical staff help improve contraceptive access? I think that's something that a lot of our providers rely on, is their in-office staff, and how can they really work to their full potential to ensure access for patients?
Linda, do you want to start this one off and I'll jump in since I did the last one?
Yeah, I can start off. So I think really valuing the team approach in your office is one way to do that. And, having team meetings where you really listen to the concerns of everybody on your staff and make everybody feel included in the team is one way to help ensure that everybody is utilized to their best ability. Listening to the questions that your staff may have, being open to having them present those questions, right? That that old adage, there's no bad question, because we can guarantee that if one person has a question, there's probably two other people that also have that question but weren't comfortable with bringing it up. So trying to develop the atmosphere in your office or in your clinic where you listen to everybody's concerns, and those concerns are included as a team as you make a plan to trying to address developing the best systems for care for patients. Brittany?
Yeah, I would also add that when we think about strategies to improve access, one of our priorities is that this can't all be things that we're just putting on the shoulders of providers. We are asking a lot of our providers on a daily basis in terms of screening and billing, coding, and high quality services. So we want to make sure that we're not putting all of these initiatives on the back of providers. But the same comes, when thinking about all forms of staff. So by sharing that workload and having a couple of really small but feasible changes that can happen on a daily basis, things like slowly adding in additional screening questions and seeing how that goes, and having team meetings that discuss why we're asking these questions, so that individuals on the phones have a real buy-in and appreciation, can really help with some of that resistance to change that's such a barrier to implementing best practices and things like that. I also think that implicit bias training can be incredibly important as it relates to individuals that may be engaging with patients, when they're coming in for their appointment and doing the intake, or when they're scheduling an appointment on the phone. We all get busy in our workday, and it can be really easy to kind of have a tone or respond to a question in a certain way that may not seem like a big deal to the individual in the hundreds of calls they answer in a day, but could make a patient not show up for their appointment or feel less likely to be forthcoming about an issue or concern that they're having. And bias training is a big part of addressing that. So making sure that you're including all members of your staff in those initiatives, rather than excluding them from it, but then asking them to do some extra work, as a result of it, can be really helpful.
Great, thank you both. And another really important question, given the governor's recent executive order on doulas, what is the role of community health workers and doulas in reaching out and engaging women of reproductive age?
So, go ahead, Linda.
Well, so they're both very valuable additions, to the healthcare team. And I think one of the good things about the executive order that came out is recognizing doulas, and it didn't recognize community health workers because it was just specifically talking about birth. But both of these professionals can be are members of the healthcare team. So I think one of the good things about the executive order is that transition in looking, sometimes institutions are looking at doulas and other kinds of workers in the community as support people, and they do certainly offer support, but they're also members of the team. So perhaps engaging with them in order to improve access to reproductive health is one thing that we can absolutely do.
Yeah, I also think, when we talked about the importance of community engagement, one of the most important things as it relates to that is, getting out into your community in a really meaningful way, and also inviting the community into your office. So Linda discussed, student support groups in your office, or going to health fairs and things like that. But in order to make sure that you're getting, the most valuable feedback from the community, having an individual that is from that community that has shared lived experience with the individuals that you're trying to reach can really go a long way in that. And I think similar to what we were discussing about maximizing the full care team, really valuing and prioritizing that unique lens that people like community health workers and those can give to your care team is really important. It's not enough just to kind of include them on a consumer advisory board or have them, at a couple of staff meetings, but really making space and pulling out what their are, the issues that they may be seeing in an approach, and valuing and acting on that is really essential.
Great, thank you. And I saw, Linda, you just added to the chat box an answer to the question that we had. So for folks on the line, the question was, is there any implicit bias training programs that you can recommend? So there will be state-provided training for hospitals and FQHCs, and we can also get back to you offline on maybe some other options. So wanted to see if there are any other last-minute questions. We do have a couple of minutes left. Want to make sure that we answer any questions that you might have before we sign off today. In the meantime, while we're waiting for one or two, I do want to just add our slides back up on the screen here so that you can see our contact information again, and make sure that you have the ability to access our RHAP provider toolkit. So our website is up on the screen, our social media handles are there, as well as our contact information. So if you do have questions or want to reach out after the presentation, please feel free to use the contact information up on your screen there. And all of those toolkit and resources that Brittany mentioned are on our website and are available for your use. And I'm not seeing any other questions coming in as of now. So Brittany, Linda, do either of you have any other closing comments that you wanted to make, or anything else that you wanted to offer before we sign off today?
Well, I want to thank Linda for her participation in this webinar and for her role in the RHAP project as a whole. And I also wanted to raise for folks on the phone, you know, the question about FQHCs was great. And we also would really love to hear any other barriers that you and your providers are facing, so that we can help really gather those and hopefully, you know, come to some solutions and use that to inform what we're addressing in our work. So, you know, we would love to talk with you more about disseminating the toolkit and the content that's in there, but also barriers that we may not have addressed or are deeply dove into in this work. We're really interested in hearing about those so we can hopefully support providers in the healthcare system that are interested in providing all these options of contraception and help find ways that they can do that most appropriately.
Great. Thank you.
Yeah, I just want to thank everybody for joining us. And, you know, like, you know, in 45 minutes, you can't cover everything, but we whetted your appetite to look more into the toolkit so that you can get more information. And we really do understand that there are policy barriers, and that's kind of like step 2 in the work that we're doing, is trying to look at some of those policy barriers and how we can address those policy barriers to reduce those barriers and increase access for people in our state that deserve full access to the full scope of reproductive health services. Thank you.
Great. And for everybody who's on, the webinar recording will be emailed out to everybody, as well as posted to our website later this afternoon, as well as the slides. So if you're looking to rewatch the presentation or send it to any of your colleagues, please check back on our website. And with that, thank you to both Brittany and to Linda for being such great speakers and offering such great information. And thank you all for joining us. We'll hope you have a great day. Thanks so much.
Thank you.